Hello, greetings. Mark Boswell with Boswell Emergency Medical Education Technology. At this time, we're going to go through the presentation on patient care management for the CEN exam. This is a chapter or a section from a blueprint that includes a lot of those other things that we do or is relevant to emergency nursing and emergency practice that impacts it. Some of the topics we're going to go through are some professional issues, transfers, minors, patient education, disaster response, and things similar to that. And you can always, if you want more information about any of the classes I do, or access to the online classes we do, or in person, you can always access at www.passthecen.com. There you can find the email address and the phone number if you need to contact me, as well as the information to follow the Facebook business page that has even more information about classes as well too. So starting with EMTALA, so this is a piece of legislative work that plays a large role in what we do in emergency care. EMTALA means or provides for the fact that anybody that presents asking for care to an emergency department is legally bound to receive a medical screening exam. That exam is designed to determine if there's an emergency medical condition. If an emergency medical condition exists, then there is an obligation for that facility to take care of that patient. If no emergency medical condition exists, as evidenced by the medical screening exam, then there is no obligation to treat. The obligation legally ends at that point. Medical screening exam is basically a provider assessing the patient, and it could be a very brief assessment or it could be more in depth to see if there's an emergency condition that really is present there. The MSE may require x-rays and lab tests, but it does not mandate that those have to be done. It would be on a case-by-case basis if that was necessary or not. It's up to the provider to know how to deliver this medical screening exam. In very few states, there are some provisions for certain nurses to do an MSE. That's not universal. That would not be assumed to be the case on the CEN exam. For the CEN exam, the universal that everybody does at a minimum is you have to have a provider do this. And one of the things is we should not, well, I'm not saying we should not, but you cannot delay the MSE to ask for insurance coverage information. That MSE is provided regardless of the ability to pay. So one of the things we're looking for is is this patient stable? What does stable mean? Stable infers that this patient should not deteriorate from whatever their condition is, either during their care or if they're being transferred to another facility. So stable implies that they're stable. If there's a patient in labor, that patient requires treatment until both the baby and the placenta have been delivered. The key, when we talk about OBGYN stuff, delivery is not finished until the placenta is delivered, so that's part of it. Talking about transfers. If we need to transfer a patient to a different facility for whatever reason, maybe the facility you're at doesn't have that level of care or that specialty, or maybe does not have capacity and you have arrangements with other facilities to take your overflow patients, for whatever the reason, we might transfer a patient. It does require written consent, and the patient or the family has to understand the risks and benefits of the transfer. There's a lot of documentation that goes with this, and as far as nursing goes, if there's any issue with any of the consultants not showing up to see the patient or to do their medical care, this information needs to be on the transfer record because the receiving facility needs to know if that patient was or was not seen by the consultant. There's going to be coordination between the sending physician and the receiving physician. All the responsibility for the transfer legally relies upon the sending facility. One of the things we're going to find out is, does the receiving facility have bed space? Now, I know in today's ER culture, sometimes the hospital's full and these patients wind up coming to the ER and you're like, what? We don't have bed space. We're not going to get down to the semantics of that, and a lot of that has to do with administrative policies and practices and all that, but I'm just telling you, transfer guidelines say you should have bed space available for that patient to go to that other facility. We have to consider what type of transport they need. We want to make sure they have the experience and the qualifications to take care of this patient while en route to their facility. The transfer summary is a document that specifically outlines certain points to meet the requirements of regulations. It needs to indicate the physician's certification. It needs to have all your patient identifiers. It's going to include basically their HPI, the history of present illness. Basically, what did they come in for, and what was the circumstances? What was the history behind this? We need to see documentation of their condition and vital signs during all stages of their care, not just a triage set of vital signs. At a minimum, you're looking at a triage set and then a discharge set. All copies of labs and x-rays need to go with the patient. Even if you're transferring to a networked facility that you may share stuff via the internet, with corporate servers, it's never a bad idea to ensure that you have hard copies as well too. What if that server goes down? What if the people on the receiving end have some problem connecting to the server and they don't have these results? So it's always good to have that backup paper copy. You're going to document any fluids received by the patient. You're going to document any medications given, any treatments you did. Some things to consider when setting up a transport. What will be the level of care this patient needs? Some patients don't require more than just basic life support, meaning just basic care. Maybe an EMT basic could transport them. Some, of course, require critical care or specialty care, like pediatrics, neonates, obstetrical emergencies, those kind of things. Consider space limitations. The back of some of these ambulances and helicopters is not very big, and sometimes some of these devices and things we have on the patients might need to be changed out. Maybe we got that long traction device on a leg. Maybe it's more ideal to change it out to the EMS one that's a bit shorter. Consider the time. Obviously, air is faster for the most part than ground, depending on weather. Is this a patient that needs to be transported more expeditiously or not? Qualifications of the personnel. Your state may mandate that it has, for example, if a patient's on a vasoactive drip, your state EMS may mandate that a critical care paramedic needs to be part of that transport. So just make sure you're aware of the special needs. Not all families have cars. Sometimes the family rode with the patient to the hospital, and then you're transferring them out, and now they're stuck there. So maybe there's some considerations for that, some alternate arrangements for the family too. Never let the family leave the ER before the patient. Probably one of the worst case scenarios is to let the family leave and they start heading towards the other hospital, and then suddenly the patient deteriorates and crashes, and they show up at the other hospital an hour later. Well, where's our father? Well, he never made it. So patient goes first, family can follow them, and make sure they know where they're going. They're going to try and keep up with that ambulance, but sometimes they don't, or maybe they have to make a stop by the house to get some items or something, or some meds from home for a family member, whatever. So make sure they know exactly where they're going. As far as ground transport, it depends upon the level of care that patient needs, as well as availability. There may not be an advanced life support unit. They may have plenty of BLS units, and you have a critical care patient, but their ALS units are tied up. So now you have to consider maybe they need to fly. So of course, a lot of your supervisors, managers, and administrators are working this process behind the scenes. Some hospitals, it's not up to the staff nurse to coordinate, but these are the things they're looking at. If we decide to go by air, it's either going to be rotary, i.e. a helicopter, or fixed wing, which is an airplane. Considerations with that. The helicopter can usually arrive and load much faster. Usually you have a helipad or some landing zone near your facility. If you're going by fixed wing, that requires an airport. So you have to consider that. How far is the nearest airport that this fixed wing could use? Of course, by the time they land, they have to unload all their gear. They usually have an ambulance there waiting for the crew. And then the ambulance has to bring them to the hospital. Then you have to load them up, then bring them back to the runway, get them on the airplane, get them all situated. They have to file their flight plans, a lot of the regulatory stuff that goes with flight stuff. So a fixed wing is going to take a lot of time. So you're probably not seeing your critical unstable patients doing that, unless maybe like you're up in Canada. Well, of course, this is the USA, but up in Canada, sometimes they have out in the very rural areas, remote areas, that's all they can do is fly the patients. And sometimes it's multiple hours to get to the closest facility. So just things to think about. If they are going by air, there's a few things we want to be aware of and consider. Remember, if they're going up to a higher altitude, we have to start thinking about pressurization issues. There's obviously less atmospheric pressure at higher altitudes. And one of the big laws of flight physiology is the expansion of gases. And at a higher altitude, gases expand. So their stomach, maybe they want to put an NG tube down to keep the gas in the stomach from expanding. because that NG tube would suck the gas out. The ET tube, we want to have now the paramedics know, the flight medics and the flight nurses, they know about this stuff, but these are things they're thinking about, and we could think ahead and work with them to kind of coordinate as they're loading up. They might want to decrease the pressure in the ET cuff a little bit so it doesn't expand and cause tracheal damage. If they have a pneumothorax, that needs to be decompressed before they go airborne, because that pneumothorax can get bigger and cause possibly a tension pneumothorax if they're in the air. So think about all these things that contain air or gases. And again, the flight crews will know this stuff, and they're supposed to check it and double check it before they go, and they'll make the adjustments they need. But it's helpful for us as normal ER staff to be a part of this team effort and kind of be thinking ahead, like at least we understand why they're asking to make sure that Heimlich valve is on there for the pneumothorax, not to the drainage unit. Okay, a little more legal consideration here. So our HIPAA laws stands for Health Insurance Portability and Accountability Act, HIPAA. Many people spell that wrong. This is actually a legal mandate. It is statutory law. The intent of HIPAA was to protect the health insurance of the individual by protecting certain information. We call that PHI, protected health information, from being released when it did not need to be, that it could influence their care to the detriment. For example, if there was something in a person's history, so maybe you're transferring someone, referring someone for a fractured femur, and they also have a history of some social disease or infectious disease, that's not unless that's germane to the case, that's not something that needs to necessarily be shared. So it's about protected health information. Now, if someone's involved in the patient's care, then they have a right to access that information if it helps to provide for their care. So and we've really stretched HIPAA to think it was a total privacy thing. It is and it isn't. We've always had a privacy obligation as healthcare people. We've always had that from day one. When we were in nursing school, we were talking about patient privacy. HIPAA is more addressing the legal side of things as far as protecting them from continuance of coverage and things like that. Another phrase relevant to HIPAA is what they call covered entities. And that's basically the entity that's involved in that patient care. So whether it be a healthcare facility, a physician's office, a physician's practice, a specific service line, the covered entities, then they can disclose that if it facilitates patient care. Okay, not for payment, but for patient care, you can disclose PHI. Now, every facility, especially hospitals where most ER nurses work, has policies in place for how HIPAA is implemented, but those are the basics of it. Is to protect their protected health information. Consent. Okay, interesting enough, there is no law that says you have to get consent. However, I would, obviously best practices said that's a good thing to do, is to get consent. Let the person be involved in making that decision there. Okay. Informed consent means the patient understands what's about to happen. They've been informed. They've been advised of risks and benefits. They've been allowed to ask questions. They've been offered alternatives if there are alternatives available. And therefore they're making an informed decision. If the patient cannot sign, either they're unconscious or they're incompetent or whatever, you need 2 witnesses to verify that's the person that the consent is for. Express consent is when the person verbally acknowledges and gives permission to consent to whatever. Okay? You see this most often when they sign their forms, when they register into the ER, their permission for the doctor to treat them forms. That's their basic consent form. They are expressing that consent. So this implies a person's competent, awake, alert, and oriented. Implied consent is typically in these critical situations where, let's face it, if you got a trauma patient, the registration clerk it's not appropriate to be there at the bedside saying, hey, can you sign this with your, I see your other arm's been amputated. Can you sign this with your other hand? No, that's implied consent. In other words, this is a critical situation or they're unconscious. It's assumed that they would want to be treated. Now, as soon as that maybe changes, that they become conscious or whatever, good care says you would go back and explain to them and eventually, hopefully have them sign the consent form even after the fact. Involuntary consent is when medical treatment is given and the patient is possibly even refusing. Okay. Now, this requires if a treatment is indicated and the attending physician feels it's warranted, and the person cannot give consent or refuses, it requires a second professional. In most facilities, this is going to be another physician. A lot of places, there's more than one ER doctor on duty. And so usually they just work with their partner, say, hey, I've got this guy over in room so-and-so. He's either inebriated or whatever. He's refusing whatever. And they'll talk to each other and they'll co-sign this form. Some places where you only have one doctor on duty at a given time, it's a little different scenario how that's going to work. But it does require 2 medical professionals. And a lot of this is going to be your behavioral patients, you know, your mental health issues, your drug and substance abuses, your intoxicated patients. Now, obviously, it's good care if when they become, when their inebriation or whatever is preventing them from consenting. Once they're back to baseline, it's always a good idea to go back and also get their express consent as well, too. That's just good care. All right, so for that informed consent, that's the one where you're explaining a procedure that you're fixing to do and making sure it's okay with the patient. For example, we're going to do conscious sedation for your broken wrist, Mr. Smith. So there's 3 things required. You've got to explain what's going to happen. You've got to offer available alternatives if there are any. And then obviously the risks. Those are the 3 minimal components for informed consent. If we're doing a surgery or a procedure and there's no consent, your legal definition is battery. That's touching a patient without their permission. If it's performed without informed consent, that is negligence. Now, I just told you there's no law that says you have to get consent, but it is considered less than adequate practice. That's why it's considered negligent. In other words, a good clinician, even though the law does not mandate you have to get informed consent, a good clinician will still get informed consent. Negligence means you're not providing the standard of care that likewise peers with likewise training in similar circumstances would do. And here's the other thing for negligence. It has to result in some injury. So are there some, if there's no injury, does that truly mean no harm, no foul? Yes and no. Could the patient still have a claim for some possible liability against the provider? Possibly. But does it meet the term of negligence? Negligence implies some injury had to have happened, some damage, some detriment as a result of whatever the treatment was. So in a court, they'd have to prove 4 things for negligence. They have to prove that there's a duty to act. Once that person presents to the ER and they're evaluated and their medical screening exam says they have an emergency medical condition, there's a duty to act. Did someone breach that duty or that agreement? In other words, did they not provide the standard of care? And then the proximate cause mean because they did not provide the standard of care, did that cause their detriment? Did that cause their decline? And then what's their damages? So these are the 4 components of negligence there. All right. Assault and battery, we kind of mix these terms up sometimes. Assault is an attempt or a threat, like intimidation, upon another person or possessions without consent. So we've got to be careful with this because it can be perceived differently by different patients. So we want to make sure that we don't have that intimidating, threatening type posture because that's considered assault also. Okay. Battery is when it actually happens. The contact has been made, okay, with the person or the possessions without their understanding. Some issues with minors. So states are going to vary as far as their definition of what a minor is. There's some variability on that. There's not a universal. In general, you could assume under 18 is a minor. There are some special situations. A lot of states have exceptions for this. If a minor presents for care and certain of these scenarios are part of their care, then there's usually some state exceptions as far as what can be done for a minor without getting consent from a parent. So frequently, many states have STD laws that if a minor presents for care for an STD, we're going to give that to them. They don't need to have parent consent. The definition of emancipated, that varies by state. But whatever your state definition is, that means they're under minor age, but they are treated like an adult. Probably the most common scenario you'll see with this is a young girl who's under 18 who's had a baby. So she's only 16 years old, but because she's had a baby, a lot of states consider her emancipated and she can give her own consent. If a minor does show up without parents, we should make an effort to contact them if they're not emancipated. We should do some due diligence and make sure you document that. And then if you cannot reach the parents, then minor's consent applies in most emergencies, which is we need to do what's in the best interest of that child. So obviously, like it's kind of a no-brainer. If they're a trauma patient, we're going to start treating them even though the parents aren't there. Now, if the kid comes in with a, I don't know, mild cellulitis of their lower leg and they're fine and their medical screening exam is negative for an emergency condition, do some facilities say, hey, we can't treat you further till we get your parent? Possibly, but what's in their best interest? Always consider that. In various states, you have different laws about what's reportable and what's not. One of the big general concepts here is usually anything that involves violence is reportable. And the way you report things varies from place to place. A lot of times you just contact law enforcement. Sometimes you just have to contact like your house supervisor, administrator, and they take it from there. But most of these are violent crimes. Of course, any of our abuse type situations, that's universal across all states. Our special populations, our vulnerable populations are protected. And poisonings, overdoses, there's a lot of variance on that. Dog bites, that's a common reason for ER visits. And that's going to vary as far as how you report those. Some places, they may have like an 800 number you have to call 24 hours a day and just leave a message. I've seen other places where we just fax a form to a 24-hour fax line, and then they take it from there the next day. I've seen some places we actually have to call the on-call animal control officer and run the case by them. But dog bites are a very common reason for reporting stuff. Getting a blood alcohol level. So we get involved in this a lot of times as it's a legal draw, because a lot of times we'll have law enforcement bring a patient or victim in, and the concern is possible driving under the influence, and they're asking for a legal blood draw. Depends on your state how that works. I wish there was a universal answer to that. However, let's assume the easiest course on this. Ask the patient. If the patient consents to it, no big deal. Document they consented to it. Document will explain to them. It gets fuzzy when the patient refuses, okay? It gets kind of murky waters there. Now, if the law enforcement has a legal warrant, they're basically under the custody of that state. I almost say you're still going to defer to your local policies. I have worked at other facilities, one of which was where only the charge nurse could do the legal blood alcohols. In other words, they're trying to keep that potential for getting subpoena and legal issues with just that one person, not against them, but looking for consistency as far as it being done. Saying, yes, every legal blood alcohol that comes in on night shift on Monday, Wednesday, Friday, that is nurse so-and-so. She's our draw person. Okay? And at the end of the day, don't force the patient, be safe. If the law enforcement officer cannot document a warrant and the patient refuses, do not do it. Worst case scenario, always get your supervisor involved. Best case scenario, the patient says, sure, go ahead. CISD. There's a lot of research and talk about this. Is it really worthwhile? Things like that. The ENA still encourages this. These CISD sessions, they can be held under various means and methods. It's all basically the same thing. It's basically some going back through a critical incident and seeing what could we do different? What do we learn from this? Where are some opportunities for improvement, as well as looking at some of the emotional responses of the caregivers and the people involved. It should be confidential. There should be no record keeping. This is not related to any patient care. It's just a verbal, okay? And only people involved, okay? The people that heard about, people that came in on day shift that heard about something that happened the night before, they're not part of this. Only the people directly involved in that care. And it's basically supposed to be an open, non-threatening forum. A lot of facilities actually have skilled, qualified counselors to come in and administer one of these sessions. You want to do it as soon as possible after the incident, while the feelings and the thoughts are fresh. We don't want people to be mulling this stuff over and making things worse by brushing it under the carpet, so to speak. There's actually some positive things that can come out of this. Some group acknowledgement, being able to express your feelings and vent about things. As far as the evidence base, I'm not really completely sure, but this is still something the ENA recommends as far as some type of response to these critical incidents. Delegation and assigning. So this is a nursing topic here as far as our nursing licenses and what are our responsibilities. I'm going to caveat all of this by saying your state board of nursing may have specific statements about what can and cannot be delegated or assigned. The general statement is If you're delegating, it's usually just a technical task or a skill, okay? Like maybe if you're in an ER that has paramedics, the paramedics starting an IV is a delegated task from nursing. It's just he's only involved to start that IV. The nurse gave him that technical thing to do. Professional activities cannot be delegated. Those are things that define your profession. One of the things as far as registered nurses go that separate us from LPNs is we have the training and the ability and the scope to assess and make a nursing diagnosis. Oh my gosh, nursing diagnosis, crazy. So we can't give that away to an LPN or a paramedic. They cannot make an assessment. Well, they can do a physical, they cannot do an assessment for the part of making a nursing diagnosis. That is reserved to registered nurses. Assigning is actually transferring basically everything, like the entire patient care, okay? But you gotta make sure that the patient needs are within their scope of practice. So it would not be appropriate for a registered nurse to assign room 4, who's on an iPride drip, to an LPN. I mean, you could, but that LPN is not empowered to titrate that drip to the parameters. The LPN can still watch it and let the RN know if the vital signs are changing, but it would not be really appropriate to assign that patient to that LPN. Forensics. So we're talking about things like sexual assault, some of our violent crimes. We need to ensure a chain of custody. And the way you actually do that may vary a little bit from place to place, but in essence, a chain of custody is basically the documentation or the paper trail of where and when and how and who had control of that evidence. So if we need to track down where that chain of custody may have been violated, we know where the break was. So this is where you have forms, you might have documents, you might have labels, you might have certain bags or containers that require a lot of documentation, date, time, place, who'd you hand it off to, things like that, and who signed for it, right? Keeping that evidence chain intact. If we're involved in any forensic type assessment, like a sexual assault thing, we're going to use direct quotes from the patient. We don't summarize what they said. If you're doing things like a gunshot wound, we don't document entrance or exit wounds. We just document a hole in the front of the chest and a hole in the back of the chest. If it's possible and stable and safe, any wounds that are on the patient, consider holding off. Like for example, someone got stabbed or something, or slashed. If they're not critically going to hemorrhage or something bad happened because of that, and you're waiting on law enforcement to show up and get some information, hold off if you can, because sometimes they're going to be taking photographs, and sometimes they actually need to see it as well too, so they can document in their law enforcement report what that wound actually looks like. Restraints, this is a big issue, isn't it? Restraints are not regulated by the state. They're not regulated by law. They are guidelines and recommendations from our accrediting bodies, okay? Joint Commission and Center for Medicare, Medicaid Services. Some key points are we don't want to use restraints if we don't have to. Any restraint, even used appropriately, safely, and correctly, there's still some risk of something going wrong. There's no perfect restraint, okay? We're going to go from least to more. So if all I need to do is wrist restraints, just do wrist restraints. If the patient's still agitated and you do ankle restraints, do those also. So we're going to escalate that as we need to. And we want to attempt to de-escalate as the behavior is more controlled or the patient more stabilizes, okay? And so we may have to kind of go back and forth at sometimes versus more restraints versus less. Documentation is so huge with this. Okay, you really can't document enough because of the risk, and be familiar with your policies and protocols at work for restraint use. What do you have to document? Maybe you've got a certain flow sheet you have to use. Okay, if the patient's able to be involved, let the patient know what the goals are for unrestrained. For example, Mr. Smith, if you can prevent yourself from kicking, screaming, yelling, and acting out for 30 minutes while these restraints, I'll loosen one of them for you. Have these clear goals that you can work with on them, hopefully. Now, of course, some of our patients, they're not verbal or they're not mentally competent enough to be part of it. But if a patient can be a part of it, if the patient can participate in that decision-making, that's good. It gives them a little more empowerment to be in control of themselves. And there must be a time on those restraints. There must be some indication of when the patient will be reassessed. Conscious sedation or procedural sedation, this is defined as sedating the patient enough, but they can still keep their airway. In other words, you sedate them enough, they don't need to be intubated. They can still have their gag reflex, their respiratory effort is still within normal limits. And you commonly see this for a lot of our orthopedic procedures, like fracture reductions, things like that. You're going to have a facility-specific flow sheet, documentation, and guidelines. And this requires a separate consent. So even though the physician or the provider is going to get consent for fracture reduction or splint reduction and splinting, the conscious sedation needs a consent as well. So that's going to be a separate consent. Some standards of care are you have to have your resus equipment readily available and your reversal agents. So if you're given benzos, you better have your Mazicon or flumazenil handy. And one person is only involved with monitoring the patient. That person is basically like a mini CRNA. Your one job is to watch the vital signs, deal with the meds, and monitor the patient and their airway and their responses. Should not be involved whatsoever in assisting with the procedure. So, if the orthopod says, hey, here, kind of hold traction on the hand for a minute, and you're the conscious sedation person, best practice is no, you don't get involved in that. Because if something changes with the patient, you need to do something with them, and you're stuck holding that traction. And it's also distracting you from following their responses too. And you're going to have a process and a protocol for when the patient is, quote, awake enough or able to be discharged. You're going to have some certain vital sign parameters, some oxygenation numbers, things like that. Let's talk about patient and family education. So we've got three basic types of learning. Cognitive is actually the knowledge that you have. That's what this exam, the CEN exam, is actually testing, your cognitive knowledge. You have an affective learning also, and that has to do with your mental state. When I do my lectures and classes, I refer to people as, if we're talking about a CHF person, if they've cared for a CHF person in profound pulmonary edema, and they remember what he looked like, the pink frothy sputum, the rails or the rales in the lungs, the 4+ edema, that's been affective learning because they've participated in that, they've seen it, they've touched it, and that triggers a little different, higher level of learning there. Okay. Now, also, teaching education psychology also says that it involves our attitudes or values. But the easier way to think of it is it's also you being, in other words, if I try and teach a new nurse about CHF and they've never seen a CHF person before, they have really no affective cognition, no affective domain for CHF. It's just words to them. Okay. So affective has more to do with being there, seeing that, doing that, and it reminds us how we felt and how we process that. Psychomotor, that's our skills. That's where, like when we do ACLS or BLS, those skill stations or TNCC, that's a psychomotor domain. Part of teaching is to have discussion. Okay, and it's always ideal if you can encourage discussion with your patient rather than just reading something to them, that kind of get a two-way conversation going. This is also how we do things like in the classroom setting. If we're having a class and then we encourage open discussion, it allows people to discuss what they think about something or what they've heard or whatever. It allows that to go back and forth between the teacher and the learner, whether it be a nurse and a patient going home or an instructor and a nursing student. Visual aids help to enhance learning. It's one thing just to sit and listen. So that's why you have slides here for some visual aids. It helps to see the practicality of things. Like when we do the respiratory lecture and we talk about the needle decompression, if I'm doing a live class, I actually carry several of the big decompressive needles, which are bigger than a lot of people think, and we pass them around. In online classes, I have slides of them so they can actually see them, because a lot of people have never done a needle decompression, and they would think you just get a 14 gauge IV, and that's not the case. Lecturing, which is also considered didactic, it is pretty quick, but not always the best way. That's what we're doing right now, is lecturing, because you don't have an opportunity to ask questions back and forth. We don't have an opportunity for open discussion. I do have some visual aids, but there's really nothing in this lecture that is a visual aid per se, like showing you a device or something like that. But didactic is that's what a lot of us are used to, is sitting in a classroom and someone lecturing or presenting stuff. For an effective teaching process, what are my patients' needs? obviously their needs that time are relevant to whatever we're discharging, whatever condition they have, things like that. Are they able to learn? If the patient's still there writhing in pain from their kidney stone, probably not a good teaching moment for them, right? Somehow we want to evaluate if our teaching's been effective. So we might throw in a few questions like, okay, Mr. Smith, we talked about you need to call your doctor if what happens, you know, and you want to hear that you told him about if he starts getting a fever, drainage, or discharge from his laceration, things like that. And then if applicable, return demonstration. So if there's any devices involved, I don't know, like a nebulizer, a peak flow meter, crutches, have the patient show you that they can do what you explained to them to do. Documentation. So every patient gets a medical record. Now, sometimes it's kind of hard to keep up with that. Most of us are all computerized now. I know there's issues with that as far as trying to get into the record and is the patient been triaged yet and all that. Just let's pretend we're in the perfect world. The perfect world, we don't have to worry about that stuff. We still need to have a medical record of some kind, of some way. We have to document the care that's been given. Okay, there's a legal imperative, there's an implied legal imperative to it, and there may be other regulatory issues. It gets sticky when you have your critical or rapidly changing situations because it's hard to keep up with stuff. Usually most trauma resuscitations will have a dedicated record-keeping nurse. Basically, that nurse is sitting back at a table or a desk, basically taking notes of what's going on, recording while the other people are actually doing the interventions. And that helps somewhat. A big thing of documentation, if you identify a problem in your patient, let's say you're doing your routine assessment and you identify abnormal lung sounds, you better have an entry at some point that says what you did about it. That is a huge open liability for a nurse to identify a problem and have nothing, no documentation show that it was addressed or dealt with. One of our charting styles is documentation by exception. That basically assumes that the patient is completely normal, except for whatever you document. You gotta be really careful with this. Make sure you know what your normal is. If you're normal for, let's say for their cardiovascular system, if their normal is that there is no S3 or S4 present, you need to make sure there's no S3 or S4 present. Because just by you hearing S1 and S2 and saying cardiac normal, and really that means that there's, you know, so make sure that you know what your exception is. Parts of our documentation, we're going to obviously our patient assessment is documented, any interventions. And again, if you find a problem, it needs to be addressed. That doesn't mean you have to fix it, but you need to have some statement about what was done. So I noticed there was 4+ pitting edema. Okay. What did I do about it? I discussed with physician that patient also reports 4+ pitting edema. Yeah, it's kind of like putting the ball off on them, but it shows you did something about it. Because the worst thing to do is have nothing documented. Okay. Full names and titles and credentials, of course. Any conversations with physicians, you say, Dr. So-and-so notified of this, etc. And then we actually get to the discharge teaching. We're going to talk about, and again, you may have some computerized processes for this, but let's pretend you had to do a paper chart. You would state somewhere, patient taught about crutches, showed how to use them, patient returned demonstrated the crutches. We're going to acknowledge somewhere in the chart that patient understands their instructions. And all these printed out instructions and handouts we give the patients, they're supposed to be written at the 6th grade level. I know it's not your decision to assess for that. I'm going to let you know the manufacturers and the companies that design these software things, that's their goal, is to make it at a 6th grade level. And of course, make sure it's in their native language. Does no good if it's a Latino who speaks 0 English to give them a stack of papers in English. I think that's a common sense thing. Disasters. So a disaster is sudden and unexpected, like out of nowhere. We're not planning for this. And because of that suddenness, it demands an immediate response and usually multiple resources, okay, both public and private. So probably some governmental resources as well as some other private ones as well too. Each community defines its own disaster. What may be a community for one, what may be a disaster for one community, maybe the day-to-day for a bigger community. So it depends upon the local resources in that area immediately impacted. We've got natural disasters like weather-related is probably the most common one you think of. And then man-made. So those are things due to the human condition, explosions, fires. Of course, you think about things like, terrorist attacks. So the federal government has a response to this, and it's called the National Disaster Medical System, NDMS. What this is an agency that can rapidly come in and help efficiently start managing things and provide some immediate support when the initial communities may still be trying to ramp up their own infrastructure. These people, I actually work for NDMS, we can actually be on site doing patient care within 24 hours, like actually with a fully functional portable hospital. We actually can be out the door when our team commander calls us when we're on call. We can actually be out the door no later than 12 hours and on site and ready to go by 24. Some places they can respond a little quicker. And sometimes when there's a known natural disaster fixing to occur, the NDMS is already deployed and waiting. Like if they know a hurricane's fixing to hit South Florida, a lot of times NDMS already have teams staged around that area a day or two before it hits. So they're ready to go basically. But it's a federal response. They cannot be activated unless the state governor asks for them. Okay, they cannot come and take over. That's one of the things that makes our country and our government unique. Well, not necessarily unique, but makes it a check and balance. The states are autonomous. Okay, the Fed cannot come in unless the governor of the state says, I want your help. The Fed could sit there and say, hey, we're here, we're ready, just give us a call, we'll send some guys down, we'll send some resources. Hey, it's looking pretty bad for you, Mr. Governor. Sure, I mean, they would really coordinate with them, but they cannot come in and take over. They cannot come in unless the governor asks for it. That provides for that state to be autonomous. Now, once they do come in, then they do assume some role there, but there's very strict and regulated guidelines and processes for all this. The phases of a disaster. So pre-impact obviously is the beforehand, before the disaster happens, whether we know it's coming or not. Let's say, like, for example, an explosion. You don't know when an explosion is going to happen, but what are some things like a local factory that might have some chemicals in it? What are some things they do ahead of time to prevent explosions or to plan for them? Okay. Hurricane, we have pre-impact notifications that we know when that hurricane's coming for the most part. We know a week out, 4 days out, 2 days out. All right. And that's where you do the prevention and the mitigation, looking at what the possible risks are. Impact is when it actually occurs. Boom, it's happened, whether we had notification or not. And then the rescue and response, that's the work. That's the work that's being done to help save lives and minimize further damage. It requires a lot of supplies and resources. This is probably the most labor-intensive part, is that initial rescue response. The post-impact, that's the long-term. Those are the ongoing days, weeks, months later, where things kind of get back to normal. There's a lot, repairs going on, resources are restocked, communities start to thrive again, things like that. The honeymoon phase, that's after the initial shock, and people are like, sigh of relief. They're like, oh, I'm just glad, it didn't affect me, or it didn't affect me as good as it could be. Okay, and they start to realize what's actually happened. And then that ongoing rehab and reconstruction. Disaster plans. So your hospital, your facility, and your department too, departments need to have disaster plans also, has plans in place. This is a mandate, part of the facility being accredited. These plans are going to define a purpose and a scope, because these are what they're going to pull when a disaster happens. This is basically the playbook for a disaster. It's going to define what you're going to do for multiple patients, which is defined as less than 10, multiple casualty, which is less than 100, or mass casualty, which is greater than 100. And typically, now you think like, well, 100 or less. Well, 99 is a lot, right? So there's a little over. This is just a defining term here. You could also say, well, if you work in a little rural area, and let's say you have like an 8-bed ER, maybe a 30-bed hospital, 4 gunshot wounds, that's an overwhelming response. I'm pretty sure with only an 8-bed ER at night, you may only have 2 nurses. And you got 4 gunshot wounds, that's a significant event. But it's not a mass casualty, okay? I would consider that a disaster because it's overwhelming your resources, okay? But actually looking at the numbers is how you define whether it's multiple patient, casualty, or mass. So during these big events, we change our triage a little bit. We change it to disaster triage. You know, when a person comes to the ER, ideally we're triaging them to identify priorities of care. Who's the most important, who's the least, not least important, but you know what I'm saying? Who's the most sick versus the least? That's the ideal way. The whole thing about if you bed patients regardless of triage, I mean, we're not going to discuss that. That is not on the exam. But the principle of triage is to sort out and to assign acuity of care. In a disaster scenario, that is changed. Disaster triage flips it. It says, what population can I provide the most benefit for with least resources? So in a disaster triage, your green people, your walking wounded, they're the biggest population you do the most for. And it's easy to take care of them. You just tell them to get up and walk and go sit over there in that area of the football field. Let's say maybe there's like a bomb that went off in a football field. You go sit over there behind the bleachers, all you people that can walk. Okay, you've just done a lot of good for a lot of people. And we classify the rest of them based upon the significance of injury, okay? Red means emergent. These are gonna require a lot of resources, okay? And these are something that if not addressed immediately or promptly will cause further compromise. Yellow, they can have important injuries at yellow, but they can be delayed to some point, okay? Typically red needs to be seen and dealt with within an hour. Yellow, they can wait an hour or more. Green, they can wait several hours. Black, not all black are dead. Not all black tagged people are dead because they could be expectant. Okay, if you walk upon somebody and they're having agonal respirations at 3 a minute in a disaster, all you do is put an oral airway in, put them on their side, and you move on. Now, if they suddenly wake up with that oral airway, different story. Okay, so dead or expectant. So if we're going to activate a disaster response, again, your facility will have a specific policy and a procedure for how this happens. It's going to be defined in the disaster plan, and the disaster plan will say how you actually do this. Okay, it'll define the resources. During the different phases of the disaster, where are your resources and how are they staged? So when you're under normal readiness, a lot of your resources may be locked away or even off campus in some storage facility. As we maybe get warning of an event, like we know that hurricane's coming, those resources, supplies, and logistics may start to get opened up and moved closer to the hospital and staged somewhere. And then under a warning phase, where we have even more increased risk, they may actually get opened up and actually spread out and deployed to the different departments. And then, of course, during the response, hopefully we already have our resources on hand, open, and ready to go. So it'll be different mobilizations depending upon what phase we're at in the disaster alert or the disaster warning process. Your department and your facility will have some type of recall system, a phone tree, or some type of notification. Okay, you may even, some hospitals communicate with their employees by text, some it's going to be by phone call, but there'll be something defined how you're going to get in touch with your staff, let them know, hey, I need you on standby, or I need you to come in, or etc. And then the other parts of the plan, there's going to be definitions of how we're going to do patient care, where we're going to do it. You may be opening up wings of the hospital that aren't normally used or normally used for certain things. There's going to be definitions of what your chain of command is. There's going to be a definition of who's your workers going to be. You know, you may have to have contracts with outside nursing agencies to say, hey, if we're in an overwhelming disaster, we've got a contract with, I don't know, Tender Loving Care nursing agency they're going to send in some additional nursing staff. And then how you go take care of the family? Because when they find out their family members, there's a patient, you can expect the family to show up also. What's your plans for that? Because they're going to be just as stressed as well too. And we do owe it to them to be able to take care of them to some degree and, you know, updates, information. And you also have a plan as far as who's going to deal with the news, the media. You know, probably have a public relations officer identified, someone from administration who will be the key person to speak to people and reporters and give updates, things like that. So how do you prepare for disasters? The biggest thing is to have drills. These are things that don't happen often, thankfully, and so they're things that we're not as familiar with actually going through it. So preparedness and drilling is one of the big things. It gives opportunities to actually do hands-on, opportunities to critically think, opportunities to get that psychomotor and that affective learning because you're actually practicing what you would actually do. gives an opportunity to ask questions, to postulate certain scenarios. Okay? It gives the leaders a chance to say, hey, is this plan really doable? Is it reasonable? You know, if I ask for, 20 ventilators, that's all nice, but do I have a place to put 20 ventilators? Where would I put them? You know, so if you actually have a drill and 20 ventilators show up, and maybe they're using maybe they're just using like cardboard boxes to simulate a ventilator. That lets you see, okay, oh, where am I going to stick these 20 pretend ventilators? I didn't think about that. And it gives us an opportunity to devise a plan B and a plan C, because as you know, plan A does not always work out. No disaster follows the rules of the playbook exactly. So after this drill, part of drilling is to generate questions and answers and thoughts and alterations or improvements. So there's always going to be some after action talk, discussion. Some places call it a hot wash. And this is going to help identify any issues or concerns that need to be dealt with. And if we identify something, we want to make sure it's followed up on. Okay, so say they determine, okay, we don't have a place for 20 ventilators. So what's the plan? Who's going to follow up on this? And what will our changes be that we can implement now that we've seen we can't put 20 ventilators just in the hallway? All right, guys, that was the end of that. That covered a majority of your topics and content for the legal, professional, and other patient care management considerations for this exam. If you want the copy of the handout, the notes to go with it, just send me an email. I'll be happy to send you that by email. You can find my email address at the website there, www.passthecen.com. Remember, I've got other videos for the other exam sections as well too. And I appreciate any comments or feedbacks or suggestions for improvement. Until then, good luck if you're studying for your CEN, and I wish you well. And in the meantime, stay safe and be well.